wondered why someone becomes breathless or confused when their body desperately needs oxygen? Now, you might think the answer is simple: low oxygen in the blood. But it's not always that straightforward. The real danger, the thing we're truly fighting, is a kind of hidden starvation that happens deep inside our tissues. And that condition, my friends, is called hypoxia. So let's break down how this hidden starvation really works. Okay, picture this. You've got a patient and they are in serious trouble. They're confused, they're gasping for air. All the classic signs are screaming lack of oxygen. But then you get the blood work back, you check their arterial oxygen level, and it's perfectly normal. How on earth is that possible? Well, this exact paradox is the key to understanding one of the most critical concepts in all of medicine. And here it is, the solution to that puzzle. It all comes down to two words that sound similar but mean very different things: hypoxemia and hypoxia. Hypoxemia, you see, is low oxygen in the blood. That's a blood problem. But hypoxia, that's low oxygen at the tissue level, where your cells actually live and work. It's a tissue problem. And here's the crucial takeaway. You can absolutely have hypoxia without having hypoxemia. Your blood can be packed with oxygen, but your cells can still be starving. So, if the blood isn't always the problem, what is? Well, to figure that out, we need to go on a little investigation. We're going to look at the four main ways our tissues can get starved of the oxygen they need to survive. Think of it like we're following the journey of a single oxygen molecule, from the air all the way down to the cell, and seeing where things can go wrong. First up, we've got hypoxic hypoxia. Now, this is the one that probably makes the most intuitive sense. The problem is right at the very beginning of the journey. We just can't get enough oxygen into the blood in the first place. Imagine your lungs are like an oxygen factory. If that factory is up at high altitude where the air is thin, it just can't pull in enough raw material. In this case, the partial pressure of arterial oxygen, what we call the PaO2, is going to be low. So what causes this in the real world? Well, being at a high altitude is the classic example. But clinically, you're going to see this with lung diseases like COPD or pneumonia, right? The lungs themselves are damaged and can't do their job. It also happens with something called hypoventilation, which is just a fancy way of saying someone isn't breathing enough to get the job done. Okay, on to our second type, anemic hypoxia. Now pay close attention here, because the PaO2 is normal. The oxygen is getting into the blood just fine. The problem isn't the supply, it's the transportation system. It's kind of like a delivery service. You've got tons of packages ready to go, but you just don't have enough delivery trucks, which in our body is hemoglobin, to actually carry them. The most obvious cause, of course, is anemia, where you literally have a shortage of hemoglobin. But there's a much more sinister cause: carbon monoxide poisoning. See, with CO poisoning, you have plenty of trucks, but they've all been hijacked. Carbon monoxide latches onto hemoglobin over 200 times more tightly than oxygen does, basically taking all your delivery trucks out of service. And this is why it's a silent killer. A standard blood test can show a totally normal PaO2, making it look like everything's fine while the patient's tissues are suffocating. Our third type is called circulatory hypoxia, sometimes called stagnant hypoxia. And again, notice the pattern here. The PaO2 is normal. The oxygen got into the blood, and there are enough hemoglobin trucks to carry it. So what's the problem now? Well, the blood itself just isn't moving. It's like a city-wide traffic jam at a complete standstill. The trucks are loaded up and ready to go, but the roads are blocked and they can't get to where they need to be. You see this on a massive system-wide scale in things like shock or heart failure, where the heart just isn't pumping effectively. But it can also happen on a really local level. For example, if a blood clot, a thrombus, blocks off an artery, it chokes off the blood flow to one specific area. And that brings us to our fourth and final type, histotoxic hypoxia. And this one is probably the most fascinating. Your PaO2 is normal, your hemoglobin is working just fine, and your blood flow is great. The delivery trucks have arrived at their destination with the packages. But the workers at the destination, the cells themselves, are essentially on strike. They are biochemically poisoned and unable to use the oxygen that has been delivered right to their front door. The classic cause of this is cyanide poisoning. Cyanide is this incredibly potent poison that goes straight for the mitochondria, the power plants of our cells, and it just shuts down the machinery that uses oxygen. So even with all the oxygen in the world right there, the cells simply can't do anything with it. All right, let's pull all this together. This slide is a big one, a definite exam point to really lock this in. You can see all four types laid out side by side. But notice the most critical difference. Only hypoxic hypoxia has a low PaO2. For anemic, circulatory, and histotoxic, that arterial oxygen level can look totally fine, and that's exactly why they can be so tough to diagnose. Now, to really understand this on a deeper level, we need to talk about a concept called oxygen delivery, or DO2 for short. This isn't just about how much oxygen is in the blood, it's about the total amount of oxygen that actually gets delivered to all the tissues in your body, every single minute. It's really the ultimate report card for how well this whole system is working. And it's all captured in this one elegant little equation. Oxygen delivery equals cardiac output times arterial oxygen content. All that really means is you take how much blood you're pumping and you multiply it by how much oxygen is packed into that blood. Every single type of hypoxia we just talked about is just a failure in one of the pieces of this equation. So, we get the theory, but how does this actually look in a person? How do we spot the clues that a patient's tissues are starving for oxygen? Let's turn into medical detectives and look for the evidence. The body is smart. It sends out warning signals, and they tend to get worse over time. Early on, the body tries to compensate. A patient might feel anxious, their heart will start racing, that's tachycardia, and they'll start breathing faster, that's tachypnea. But if the problem isn't fixed, you start to see the really scary signs as the brain starts to suffer. Confusion, that bluish tint to the skin called cyanosis, and eventually coma. And we have to act fast. I mean, really fast. Why? Because the brain is the most oxygen-hungry organ we have. Without a constant supply, it can only last for about 4 to 6 minutes before irreversible brain damage starts to set in. That number right there shows you why this is such a medical emergency. So here is a massive clinical tip for you. The key test we use is an arterial blood gas, or ABG. Now, if that ABG comes back and the PO2 is normal, but your patient is clearly in distress, alarm bells should be going off in your head. You have to immediately start thinking about those other possibilities we talked about. Is it anemic hypoxia? Could it be carbon monoxide? Could it be circulatory shock? Or is it something as rare and dangerous as cyanide? Okay, we've figured out the problem, we can see the signs, we know it's urgent. Now for the most important part, the resolution. How do we fix this? How do we restore that flow of oxygen and save those starving tissues? The management strategy is actually beautifully simple. It has 2 main steps. Step 1, treat the oxygen. No matter what, your first move is almost always to give supplemental oxygen to get as much into the system as possible. But step 2 is just as critical. You have to treat the underlying cause. Just giving oxygen without fixing the root problem is like putting a bucket under a leak instead of fixing the pipe. And this is where it all comes together. The specific treatments tie right back to our 4 types. If it's hypoxic hypoxia, you need to improve their ventilation. If it's anemic, they might need a blood transfusion. For circulatory problems, you might use fluids or drugs to improve blood flow. And for histotoxic hypoxia, you're going to reach for specific antidotes to fight the poison. All right, let's wrap it up with some high-yield pearls to make sure this all sticks. Number 1, hypoxia is not the same as hypoxemia. Say it with me. Number 2, carbon monoxide poisoning is the classic trap, always presenting with a normal PO2. 3, cyanosis, that blue skin, is a late and often unreliable sign. And finally, always ask yourself this question. Is this a problem of oxygen supply, or is it a problem of oxygen utilization? So, I'll leave you with a question to think about. In our body, which organ is the canary in the coal mine for hypoxia? Which one sounds the alarm first? And why does it fail before anything else? If you can answer that, you've truly understood the real-world importance of everything we've talked about today.